Welcome, and thank you for joining us today for a public forum, Prioritizing Care During Midlife, Professional, Personal, and Healthcare Strategies for Women. I am Dr. Irene Ninye, Chief Science Officer for the Society for Women's Health Research. SWHR is a national nonprofit dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize women's health. Midlife for women is typically defined between the age of 35 and 65, whereas for men, it is between 40 and 60 years old. This period spans reproductive years and up to 10 to 20 years post-menopause. During midlife, women experience a range of physical and psychosocial changes that can have immediate and long-lasting health implications, such as bone density loss, cognitive challenges and sleep disturbances, stress related to work, and increased responsibilities caring for children and aging parents. While much of health care during midlife tends to focus on ovarian aging and estrogen depletion, providers and patients should recognize that midlife is a critical intervention point to mitigate chronic health conditions and promote wellness later in life. At SWHR, we are celebrating our 35th anniversary and entering our own midlife as an organization. Just as midlife represents a time of reflection and renewed purpose for individuals, SWHR is embracing this milestone to deepen our commitment to advancing women's health across the lifespan. And so now during National Women's Health Week, SWHR has decided to host this program to discuss the unique challenges women face during midlife, including strategies to maintain healthy work lives, needs of women serving as caregiving roles, and key health prevention and interventions to promote establishing and maintaining work-life health harmony. I'm especially pleased to introduce my fellow panelists today who are in-house leaders in public and women's health. SWHR Science Program Managers Sarah Chu and Serene Gulmamine. Sarah Chu's background is in strategic planning, communications, and health promotion research, and Serene Gulmamine's background is in epidemiology, life sciences research, and community health education. I would also like to thank the sponsors of today's event, Bonafide. SWHR maintains independence and editorial control over our program development, content, and work products. Following the speaker presentations, I will moderate a discussion with the panel or with my fellow panelists. So I invite you all to use the Q&A function to submit questions throughout this event. We will try to address as many questions as we can during the program, focusing on submissions that cover recurring themes and questions with broader applicability to the audience. So we will get started with Sarah Chu, who will talk about common health challenges during midlife and the role of prevention and intervention in women's health. You have the floor.
Thank you so much. All right, thank you and good afternoon. As Irene mentioned, I'm one of the the science program manager here at the Society, and I'm going to talk about midlife healthcare. As Dr. Ainine mentioned, midlife for women is defined by a complex overlap of reproductive and chronological aging. Data shows that risks for some diseases and conditions can accelerate during midlife, particularly due to hormonal changes, namely estrogen depletion. However, this can also be a critical intervention point and an opportunity to mitigate disease risks, chronic health conditions, and promote longevity, not only in the quantity, but the quality of women's lives. Through risk assessment, counseling, prevention, and interventions, women can improve their health in midlife and reduce their health risks in the short and long term. Midlife does not have to be a time of worsening health for women. As women enter midlife, it's important to understand what health changes are common and also what symptoms may be relevant to discuss with a provider. Women and their providers should be aware of the health risks and the health markers of midlife. Highlighted here are a few of examples of health systems in which we see changes in midlife, particularly systems in which sex hormones play an important role. These include metabolic health, brain health, heart health, bone health, cancer risk, chronic conditions, and of course, ovarian and reproductive health. Learning how and why these systems are impacted by reproductive and chronological aging is key to addressing risk factors, engaging in prevention, and receiving any necessary medical interventions to promote long-term health. I'm now going to dive into a few of these health systems and how they change during midlife. I will also highlight some specific risk factors in women and some relevant opportunities for prevention for both patients and for providers to consider. So first, cardiovascular disease. We know that cardiovascular disease is the leading cause of death among women in the United States, and age is a major risk factor for CVD. A protective factor for cardiovascular disease in women is estrogen. Thus, the menopause transition and associated estrogen depletion can profoundly affect current and future cardiometabolic health in women. We also see physiological changes in midlife in women, such as changes in blood vessel, blood pressure, and changes in cholesterol and lipids, which are all relevant to cardiovascular health. And we also can't overlook the impact of pre-existing conditions that increase in midlife, such as changes in blood pressure, elevated cholesterol, obesity, as well as changes in midlife like increasingly sedentary lifestyles and poor diet and nutrition. But to prevent CVD risk at midlife, there are opportunities for women. Women really should take this time to learn about their risk factors for cardiovascular disease, including lifestyle, smoking, nutrition. Women can also take this opportunity to know their blood pressure, know their cholesterol, and know their blood sugar levels. And providers should continue to routinely check for blood pressure, lipids, BMI, and lifestyle factors, and offer relevant and appropriate health intervention, because early detection and treatment for risk factors of CVD in midlife are key to preventing future adverse health outcomes. In terms of brain health, women often cite both subjective and objective cognitive changes as they age into midlife. And we know that data shows there are structural, functional, and cognitive changes observed in women's brains at midlife. There are structural changes like changes in volume. We also see longitudinal declines in cognitive performance, mainly in processing speed and in verbal memory. And research shows that depletion of ovarian hormones, particularly estrogen, during the menopause transition may impact neural circuits. Across women, lower concentrations of estrogen were related to greater changes in hippocampal connectivity and also poorer performance on memory retrieval tasks. Further, similar to cardiovascular disease, there is some suggestion that sex hormones may play a protective role against age-related deterioration in some cognitive functions in women. Therefore, once again, midlife is an important period in which healthy lifestyle can minimize cognitive decline and increase the brain's cognitive capacity for later life. Women should consider discussing any cognitive changes with their providers, and providers should consider offering relevant and appropriate pharmacological interventions and interventions for sleep, exercise, nutrition, and stress, as those are all related to brain health. Women should consider how engaging in a low-risk lifestyle can benefit both their physical and their cognitive health. Women make up 52% of the individuals over 50 in the US with low bone mass, and osteoporosis affects 1 in 3 women over 50 in the US. Unfortunately, bone loss accelerates during midlife. Estrogen deficiency is considered a major factor in loss of bone density in women. Therefore, in particular, transitioning through menopause during midlife does put women at risk for decreased bone density and higher risk for breaking a bone. So, midlife is an opportunity to prevent rapid bone loss and prevent fractures. Providers should be having conversations and discussing shared decision-making around bone health and osteoporosis early in women's lives in midlife in order to prevent and address the risk factors for osteoporosis. While bone density screening is not recommended until 35, women should be encouraged to talk to their doctor about if early screening is appropriate for you. Additionally, as you pass midlife, screening rates for osteoporosis in women are low, and so it's important to engage in relevant screenings as you age. Women should also consider when safe and appropriate to engage in lifestyle changes and including weight-bearing activities and resistance training to prevent bone loss in midlife. Sleep disturbances in midlife can be a result of hormone changes, vasomotor symptoms, or mood symptoms. Data shows us that sleep disturbances is often one of the most bothersome symptoms of the menopause transition. With aging and this hormonal change, women are at an increased risk for sleep disturbances such as insomnia, poor sleep quality, sleep deprivations, as well as sleep disorders such as sleep apnea, restless leg syndrome. Sleep disturbances can also contribute to other health conditions and a lower quality of life. We see that bidirectional relationship between mood and stress and other health issues like cardiovascular disease and metabolic health. Providers should consider ways in which they can address these related conditions like mood disorders, stress, and anxiety, particularly because there's evidence that suggests a relationship between sleep quality and longer-term cognitive function. To address sleep problems in midlife, women should consider prioritizing good sleep hygiene, managing stress, and underlying any medical conditions. If the sleep problems become worrisome, you should speak to your doctor about any pharmacological as well as non-pharmacological solutions that may be available to you. So these are just a few examples, and to just take a quick step back, when we think about prevention as a whole and prevention in midlife, prevention really includes a wide range of activities aimed at reducing risks or threats to health, and the goal is to maintain and promote health, reduce risk factors, diagnose illnesses early, and prevent complications. As I mentioned at the beginning of this presentation, when it comes to women's midlife health, prevention and intervention are key. As highlighted through some of the above examples, prevention and intervention in midlife must consider multiple approaches, which include both the patient and a provider, and it must be personalized to the individual. Women should consider how they can build awareness of their health risks, consider what healthy behaviors they can engage in with the help of a provider, and they should talk to their provider about screenings, and vice versa. Providers should engage in conversations about these topics. Finally, importantly, women should seek care and treat symptoms and risk factors early, because we know that many of the topics that I've highlighted here, as well as many other midlife health issues, can develop into lifelong conditions that can have significant healthcare costs and place an undue burden on both women and their families. I would also like to take a moment to acknowledge there are some relevant structural and systemic barriers that need to be addressed on a societal level in order to allow for greater prevention and intervention at midlife. And I know that my colleagues will be discussing some of these later, but I do think it's important to acknowledge that there are some barriers that women may face. So as women think about how can I engage in midlife health, and what does that look like practically? So, as I mentioned, women who are navigating this often complex and busy life, their complex and busy lives during midlife, should recognize that it is very important to prioritize their health. Speaking with providers about your lifestyle, symptoms, and risk factors, and using the help of things like journals and apps to track symptoms over time is incredibly important in midlife. Women should also share their medical lifestyle and family history, as well as their quality of life goals. It's incredibly important to address what you would like your life to look like, what you would like your health to look like as you age. And to that end, finally, it's really important to advocate for what you want from your health at midlife. Alternatively, or on the opposite side, what are the expectations for providers? Providers should be invested in preventive care. Providers should be delivering routine screenings and addressing risk factors that are individualized to their patients based on their medical, lifestyle, and family history and symptoms. Providers should also be explaining these midlife health risks in language that women understand. And they should also be paying particular attention to persistent racial and ethnic disparities in midlife preventive healthcare. All preventive healthcare recommendations from providers should consider each patient's quality of life goals, preferences, symptoms, and disease risks, and really ensure long-term health. These are just a few suggestions and opportunities for midlife health. While some things about midlife are inevitable, poor health doesn't have to be one of them. Thank you so much.
Thank you, Sarah, so much for setting that stage and talking about how midlife we can increase our health and address concerns related to our health. Next, we will welcome Serene Gulmamine, who will discuss the concept of intersectionality and its role in women's health during midlife, especially for those who are caregivers. Welcome, Serene.
Thank you, Dr. Anine. I will now share my slides if you'll give me a moment. All right. So welcome and thank you all for joining us for this important session. I'm Serene Gulmamine. I'm a Science Programs Manager at the Society for Women's Health Research. And today we'll be exploring how caregiving intersects with midlife health in women and what it means to reimagine care through a whole person health lens. Intersectionality is more than just a buzzword. It's a vital framework for understanding how overlapping identities like race, gender, disability status, caregiving status, and immigration background to name a few examples, compound or mitigate access to care and health outcomes. For midlife women, these identities shape everything from whether they can access menopause care to whether caregiving expectations are placed on them without support. Thinking about the roles that you might carry as an employee, a partner, a patient, or parent, what identities overlap in your life, and how does that affect your health? Health doesn't start in the provider's exam room. It starts in our neighborhoods, in access to transportation, paid family leave policies, and in affordable child and elder care. Social determinants of health are factors in the environment where people are born, live, learn, work, and age that affect a wide range of health functioning and quality of life outcomes and risks. And they may result in or contribute to structures and outcomes that include discrimination, access or barriers to services, stress, and mortality. Social determinants like housing stability, food security, and job quality shape women's health across the life course. And midlife is a critical turning point. So small gaps in care or stability now become major disparities later, especially for different populations of women. All determinants impact people differently, and these factors interact with our intersectional identities, including some of the things I had mentioned previously, like race, gender, caregiving roles, and employment status, to shape long-term health outcomes in midlife. Women in midlife, especially caregivers, are navigating a web of stressors at a time when their own health needs are changing. I want to draw attention to a few that are relevant in the discussion around women's health during midlife. So the first couple, food and economic security and neighborhood and environment. So where women live, work, and care matters deeply. Unsafe neighborhoods limit exercise, long commutes reduce time for self-care, and caregiving without flexibility increases burnout. Another thing I'll highlight is for healthcare and education in terms of access and quality. Health access is not just availability, it's quality and trust. Many midlife women experience dismissal of symptoms, particularly with lack of menopause transition support, or even linguistic and cultural disconnect with providers. This is not about individual behaviors, but rather structural and social systems that shape health outcomes, and midlife women often fall through the policy cracks. So what counts as caregiving? If you're helping someone manage medications, attend appointments, prepare meals, or even just checking in regularly, you're caregiving. The American Caregiver Association defines caregivers as those who offer support and assistance to individuals who need help with daily tasks, as well as managing their overall well-being. So two distinct groups I've highlighted here include formal caregivers. So those are individuals who are paid providers, licensed workers, and others associated with the formal service system, and informal caregivers, which include friends, relatives, and community members who provide care without compensation. With the average age of caregivers being around 50 years old, the prevalence of caregivers by age in this graph here shows that most midlife individuals are at a time when individuals are taking on increased caregiving roles. And while this prevalence estimate here is specific to individuals caring for an adult and children with special needs, we recognize that caregiving can take on other populations as well, as I mentioned previously, but including children, young adults, non-familial members, among others. Um, so I want to highlight here the caregiving burden. Barriers are heightened for caregivers with limited digital access, non-English speakers, or those working hourly jobs. Over 53 million Americans provide unpaid care, with nearly 3 in 5 caregivers being women. In addition, the estimated economic value of unpaid family caregiving is about 600 billion annually. Yet this vital labor is often invisible in policy, unsupported by employers, and excluded from routine medical care considerations. The work of caregivers goes beyond physical tasks. Caregivers often experience burnout and compassion fatigue, guilt for not doing enough, and isolation due to limited social time or lack of recognition, which ultimately impacts their physical, emotional, and financial health. So when considering these burdens, I urge us to stop thinking of caregiving as a private matter and more of a public health issue. Midlife is often framed as a productive or stable time, yet for women, it can be a perfect storm of caregiving and personal health demands. Women in this stage frequently care for both aging parents and growing children, often referred to as the sandwich generation. Meanwhile, they may be navigating the menopause transition, which can start as early for women in their mid to late 30s, as well as other personal health challenges such as autoimmune disease onset, metabolic changes, and mounting emotional exhaustion. These overlapping demands, including caregiving demands, personal health challenges, workforce pressures, they create a burden that's invisible to many health systems and workplaces. And the consequences, delayed screenings delayed screenings, neglecting preventative care, and then unmanaged chronic stress, all which compound future health risks. It's important to center midlife women in health policies, caregiving supports, and health access initiatives, and recognizing this life stage as one of vulnerability and opportunity. So what do caregivers need to be themselves? In terms of knowledge, I would say understanding disease processes, medications, health systems, and clear communication in culturally and linguistically appropriate formats. With regards to tools, digital apps for appointment management, home safety and mobility modifications, remote monitoring also for remote monitoring tech for parents and children also is very, very helpful. Um, and lastly, here with regards to support, navigation support like resource directories, health coaches or social workers, and then paid time off to attend medical appointments. And considering the intersectional identities our caregivers might have, these items can help meet women where they are at and close the gap. So what can you do? And these are a few tips. I will start off by saying that we need to move away from thinking of midlife caregiving as a side issue. It's a determinant of health impacting both the individual caregiver and the ones they care for. And when we think about supporting whole person health, we need really employer buy-in and federal investment. And the federal investment, particularly with regard to caregiver training, community health worker models, research and workforce pipelines. But it starts with us. So what are some things that a caregiver can do and things they can consider when they're taking care of an individual that they're caregiving for? The first one is asking recipients or loved ones about their needs. So if you have the ability to do this, giving the autonomy is key. Recipients know their needs best, so not assuming and asking how you can assist. So checking in often, and the needs may change as well, and being flexible in that regard. As a parent, some of this may look a little bit different, but involving children in their care by encouraging them to learn more and asking them about their needs for support, particularly when we're talking about school or work, is also helpful. Modifying your home environment. This can look like adding things like shower bars, or if you're a parent, like child locks, relocating frequently used items, and thinking about how can you make daily activities easier. encouraging adaptive devices, so eliminating certain emotions or making them easier. Examples include jar openers, easy grip utensils, button aids, and hands-free devices. Um, and the last one, which is, I think the most important, is really being an advocate. So offering to accompany recipients to their doctor's appointments to support their care journey, taking notes, asking questions. And caregiving is a stratified experience. I think it's important for us to elevate caregiving as a health equity issue, especially for midlife women whose contributions hold up families, communities, and the workforce. So centering the voices of caregiving in policymaking, acknowledging that unpaid labor is public health infrastructure, and designing systems that treat women not just as patients, but as whole people navigating complex lives. And I'll leave you with this last thought. How can your institutions, research topics, your personal relationships with individuals, how can you do more to center and support midlife caregiving? With that, thank you. Um, I will now welcome Dr. Irina Ninier, who will address workplace stressors and their impact on women's health during midlife.
Thank you so much, Serene, and I will go ahead. Yep. Slide. All right. Thank you so much. As as you can see, I have two amazing program managers that are well versed, and it's been a pleasure to work on this particular program with them. And so on the third end of this work-life health harmony that we are discussing today, I would like to discuss working through midlife like a boss, right? And it is very important to recognize that midlife spans from the reproductive age into postmenopause years. It is not just during menopause. However, menopause is a very important time and a transition that many women encounter or go through during midlife in those years. And so I saw a question in the chat earlier, so I mean in the Q&A, so I can just address that now, that menopause is defined as a point in time when a woman's menstrual period has stopped for 12 consecutive months. So during that time frame, sometimes women might have, 3 or 4 months, and then their cycle will come, and so you restart the clock. So as you can see on this little timeline here, your last menstrual period is actually, your menopause is defined a year after. So when that 12 months happens, you look back and you say, my menopause, the date of my menopause was 12 months ago. And so as you can see, midlife, because of its range, you have times where fertility and reproduction are still happening and still part of your health journey. Then you have this perimenopause or menopause transition, and that is part of the midlife health journey. And then going through up to 65 years old, you will be postmenopause. I majority, almost all women would have been postmenopause at that point. And so you have that stage of life as well. So it is definitely broad throughout this time. And as we mentioned earlier, that it is different. The age range or the period for men is different for women. It starts a bit earlier and ends a bit later for women than it does for men. The average age of menopause is 51. And so you'll hear me talk about menopause during my portion of this program, during my presentation, because there are certain things that are synonymous and things we want to elevate from the discussion, but recognizing that some of these challenges can span before and after the menopause transition. And so during menopause and midlife, or during those years, there's a fluctuation and decline of ovarian hormones that can cause challenges in different activity and physiology in your body. And it can go during the menopause transition and these midlife years into many years post-menopause. And so Sarah discussed the health impacts on various female processes of brain health and bone health and heart health and sleep and such. And then Serene had taken us into how this time frame can also kind of be exacerbated in some of the challenges because of all the different hats that women wear during midlife. But it's not a reason to ignore these, but really to kind of coalesce and develop some strategies on how to do it. But in the midst of addressing our health and in the midst of addressing life and all those around us, many women are working. And so we know that during this time frame with menopause, there are a lot of symptoms and challenges that women experience. They vary widely and they're very individual. But the study of women's health across the nation, known as the SWAN study, had identified that up to 20% of women delay seeking treatment for their symptoms 12 or more months. And so you can spend a year navigating whether or not you're going to go to the doctor. Is it just me? Is it a health challenge, or is it something that will pass? But it's not just these physical changes, but it's also a transformational life stage that we really do want to be able to address well. And so while we're working, the Bureau of Labor Statistics says that 26% of the US labor force are women that are in midlife. And so these years are very critical career growth years across industries. And so organizations and companies need to recognize the potential value lost if these women, this demographic, is forced to choose between their health and their livelihood. And so companies that appropriately address the menopause experience and the midlife stage for many women can increase their productivity and improve retention of talented employees throughout their workforce. This is an intergenerational issue that we have to address. And so I've put a couple of definitions on this slide: presenteeism and absenteeism. Many are familiar with absenteeism. It's the loss in productivity when you leave work. But what we often see is that women or individuals have experienced presenteeism. So they're still going to work for various reasons. Either they are unable to take off, or their job is busy, or they don't have the leave, whatever those reasons may be, but they are less productive because they're not well. They're not feeling optimally or 100% when they are on the job. And so in 2023, SWHR launched the Impact Menopause Study, which is the employee perspectives and challenges concerning the transition of menopause study. It is an ongoing study where we wanted to identify and better understand the workplace experiences of menopausal women, but as well, we wanted to understand what are the perspectives from their coworkers and their employers. And we use this data and this study to inform recommendations, resources, and programs. And I want to take the opportunity to highlight some of the results and the data from this study so you can better understand these challenges of midlife and during the midlife women. And so you see on this pie or this donut chart on the right, the top right, that speaks to the stage of the individuals that were respondents. We had 30% that were premenopause or unsure. So these are women that are not going through menopause, but many of them are going through have started or they're in midlife. Then we have the perimenopause and the postmenopause individuals. And you see a bit of an age breakdown of our respondents in the lower right corner. So we did have 30% in the 40s age range, 40% in our 50s age range, and then 65 plus. So there are a significant number of midlife individuals who were in this, who participated in this study. And I wanted to highlight the workplace industries because what was really important factor in designing the study in the outreach was that we were able to identify or bring in individuals across different industries. So it's not necessarily just the desk working or the corporate individual, but individuals across healthcare and professional jobs, administrative and government or financial services, arts and media, engineering and tech jobs, as well as the physical and service industries of retail and hospitality, transportation, engineering, and utilities and such. So we wanted to have this diverse range, and you can see that we were able to get representation across various industries. So how does menopause symptoms or how does menopause symptoms affect job functions during this time? And so the most bothersome symptoms that were identified are here. It is sleep disturbances, brain fog and difficulty concentrating, weight gain or changes in body shape, and then fluctuations in mood and PMS. And this is very interesting because I know you're probably thinking, why are hot flashes not on here? Well, hot flashes are bothersome, and there were women that reported having hot flashes, but this particular question was geared at affecting their work life. And so it doesn't negate, but these are just the top 4 symptoms out of a list of over 20 symptoms that are commonly associated that I also had listed on the earlier slide that women had identified. And so what happens, not just the symptoms being bothersome, but how does their work bothered or how is their work impacted? And so we had respondents rate how physically, cognitively, or emotionally demanding their job was. And so those that rated a highly demanding job, whether it was physical, and so that might be lifting and walking and repetitive motions, or cognitively demanding, which is, your thinking and your concentration, and then you have your emotionally demanding jobs, which might have to deal with engaging or sympathizing or working with others. And so there were also different job functions that we looked at. So it's the mental decision-making concentration, if there's social job functions of traveling, and then there's those physical ones as well. And so you see this chart on the right that if put in, and concentration or focusing on a task for an extended period of time was selected by over 60% of respondents, regardless of their job demand. So whether they had a physical, emotional, or cognitively demanding job. And I did want to note here that they were able to select the top 5 um, job functions that were disrupted due to their symptoms and their menopause experience. And so the other one I want to highlight here is decision making or problem solving or other forms of critical thinking. And it was among the top 5 selected across job types and industries, as well as interacting or meeting with other people. So this was actually very similar, whether you had a highly demanding job or or it was not, you did not have a highly demanding job physically or emotionally. And then I want to note for those who had cognitively demanding jobs, they were 2 times more frequently selecting that interacting or meeting with other people was disrupted or a challenge for them compared to those that had a low cognitive demand for their job. And so what can we do about it? We have to have policies in place. And that is really important in the workforce, that organizations are recognizing these challenges and having policies that are either specific for menopause or can be adapted. According to our respondents, whether they were employees or supervisors, only 3% of them reported having menopause-specific policies or resources in place at their workplace. But I want to call your attention to the unsure. It was almost a third, a little under a third for supervisors, a bit over a third for employees that said, and this is not just menopause employees, these are all employees and supervisors, that they were unsure. And that is bothersome because that means you don't know. And not knowing is just as detrimental as not having a policy, because if it's there and you don't know about it, you're not able to utilize it as a resource for your work-life benefit. And so some of the impacts, to reiterate from earlier, as I talked about that absenteeism and presenteeism, as we can see from women who are going through the menopause transition or have been perimenopause or postmenopause, so they're throughout this midlife timeframe, noted up to almost half of them noted that their self-confidence or esteem at work in the workplace had been affected and their overall job satisfaction and motivation. And so we see this presenteeism as well, that over a third are working while unwell. And then we see the absenteeism where there's over 10% are not, are having to take off work in order to address their symptoms. And so these broader impacts are things that we really want to address, and they're not liabilities, but we want to look at them as how can we retain and make sure that these are all things that can be accounted for and we can adjust for and accommodate in ways um, that can help to increase the work-life satisfaction and making sure that we're not losing this really important group and population in our workplaces. And so when we also asked our respondents to think about what considerations did you have in adjusting? What did you have to do, or what did you consider doing to adjust for the experiences that you were having and the challenges? And this might be reducing or changing your hours at work. We have here reducing your workload or responsibilities. Were you declining promotional opportunities or not pursuing leadership and climbing that ladder, depending on what it looks like in your industry or your workplace? Or did you look to find a new job or go into business for yourself so that you could have a bit more flexibility, or even just leaving the workforce and retiring altogether? So these were some of the considerations, and in the gray, these are those that considered making a change, and in the green are those that actually made this change. And so across the tech, media, and education industries, they were almost they selected to make a change almost 2 times more frequently than the average menopausal woman. So if you were in a tech, media, or education industry, you made the change of reducing your workload or your responsibilities twice as much as the average menopausal woman. For the physical and service industries, they consider declining the promotion opportunity 2.7 times more frequently um, than those at the average menopausal woman. So there are certain industries where we started to see these nuances and these changes. But as you can see here, regardless of industry, there's a lot of considerations being made and a lot of changes being made as well. And so it's focusing on the actual changes that were made to jobs. In the purple, we see those with physically demanding jobs. In the gray are those that have cognitively demanding jobs. Remember, that's on the intellectual side. And then on the red or pink color are the emotionally demanding jobs. And so physically demanding jobs, if you note here, were more likely to make more internal changes to their job, reducing workload or hours, not pursuing leadership, or declining promotional opportunities. Whereas those who were in cognitive or emotionally demanding jobs were more likely to exit their job, find a new one, transition to self-employment, or retire altogether. And so, that might have to do with infrastructure and the opportunities that if you are in a physically demanding job, there might require more infrastructure, for example, at a manufacturing plant that you necessarily might not be able to get that job in your same city or vicinity or do it on your own. Whereas if you have a job that might take more individual brain power, emotional power, it might translate a little bit better to entrepreneurship, or it's time for you to just retire. But these are the types of things that we feel can be highly preventable if we provide the support and the accommodations across um, life situations, social situations, healthcare, and in the workplace. And so what are some accommodations that we can consider? There are across industries, the top 5 accommodations that were selected was working from home, as we know that has become an increased option since the pandemic, flexible work hours and alternative work schedules, also temperature control. So this is an accommodation, although the most bothersome symptom might not have shown up to be hot flashes, it doesn't mean it does not affect work. And so temperature control was also selected. Workshops and training, education was definitely a need that was expressed. And then time off for medical appointments. And assuming that we cannot assume that this is a given across all jobs and across all industries, that there is enough time for medical care or sick leave. And that's why we may see some of the presenteeism or absenteeism that was reported. Other accommodations just to be able to get your thoughts brewing are dedicated personal spaces and rest areas. We see this similar in maternal health care with nursing rooms or dedicated rooms for that space. Also access to cold water cooling devices, having uniforms that might be able to be layered or flexible, adaptable in a way, thinking about materials that can be used that allow you to breathe better and allowing your skin to breathe, and shifting job duties, reducing physical labor, maybe having adaptive tools and furniture, note-taking support, now especially in a time where we have a lot of technology that can adapt for that, that we can utilize that to lift the load and reduce the burden and the challenges that are being experienced by many individuals. Also, frequent breaks are another thing. So companies that appropriately address the midlife experience can really increase their productivity, and it can improve retention of talented employees throughout their workforce. And so, as I'm coming to a close, some of the actions that organizations can take, because at SWHR, we definitely understand and we believe we want to empower women and we want to give them information, but we also recognize there are a lot of things that are systematically or systemically in place that can be challenges. And so it's not always on women. We want to also challenge organizations and companies, the healthcare system, policymakers, to do their part to also address these issues. And so an organization can partner with the health plan providers, ensuring that there's inclusive coverage, making sure that they are looking at the different requirements under federal legislation, or like disability care or age, anti-discrimination laws for age and for sex and gender. So those types of compliance is very important in this space as well. Hire and train supportive supervisors and leaders. And as you're looking to promote incorporating, understanding intergenerational inclusion in your workforce and recognizing those needs and finding ways to address them is very important. Workplace affinity groups and resource groups, employee resource groups are also very key. But highlighted in red at the bottom that I want to mention here is helping leaders to understand the impact of doing nothing. It is not it is not okay to do nothing. There's very small things that can be done, even if it's just changing the language, the environment, making it a safe space for individuals to share their challenges, providing information on how to contact HR or benefits department to figure out what needs to be done and how you can find how women can address their challenges. That's something helping to alleviate that load. And so the costs often associated with losing talent at any and all levels um, can they add up. And but the cost for a lot of accommodations can be very minimal. And so there are resources that we have put together at SWHR. We actually launched a workplace resource guide for women that talks about working through the menopause transition, which is also very applicable to midlife, crucial conversations. We have a guide for managers that focuses on understanding the menopause experience, cultivating menopause-friendly workplaces, understanding that intergenerational workforce and how it's important. And then also in both guides, resource guides, it talks about accommodations, conversations that can be had, supporting menopause and midlife. We have posters for that, and then other resources and support organizations. There's a QR code there that you can tap into. And with that, I will stop sharing my screen. And that is the close of that portion of my presentation. And I invite my colleagues, Sarah and Serene, to turn on their cameras, and we will enter our discussion portion of this event. Please, again, we invite participants to submit questions using the Q&A function within the app. We'll try to address as many individual questions and common themes as we can during the remaining, I guess, 5 to 7 minutes. And so with that, let's dive in. And I will start with a question for you, Sarah. You work across multiple topics in women's health, and you see comorbidities across all these different contexts. So what message of hope or support can you offer to women who may feel overwhelmed by all the healthcare issues they're advised to watch out for? I mean, you talked about brain and skin and sleep. That can be very overwhelming. So maybe can you shed some light on, how to kind of approach all of that?
Yeah, absolutely. It's a great question because I did present a lot of information that seemingly could be very overwhelming. But to that end, I do think it's important to remember that a little can go a long way. If you noticed in my presentation, there were a lot of common suggestions across my talk in terms of lifestyle changes that can positively impact multiple health systems. So, for example, when you think about exercise or a good nutrition and diet, these things can affect both all your heart health, your bone health, your brain health, your metabolic health. These are things that are relatively small that can have a bigger reach. And so I think there are additional examples of small things that you can do that can make it have a bigger impact. So I like to think that instead of thinking you have to do all these things or once, or that you need to do all these things, just start small. So one small change that you can make, and that one small change can actually have a large impact across health.
I'm seeing, and to kind of piggyback on that, there's a question that was submitted as well. How can women advocate for themselves when their midlife symptoms like fatigue, brain fog, or mood challenges are dismissed or diagnosed by providers?
Absolutely. I mean, I think that's true about a lot of women's health conditions. That's a conversation we have often at SWHR is, what do you do if you're feeling like you're being dismissed or you're being misdiagnosed? And I think a large part of that obviously happens at a systemic level, as we mentioned, that it's around understanding women's midlife health and also getting providers to recognize these things. But I also think from an individual perspective, continuing to advocate for your needs and your wants, and also when possible, finding a provider who will listen to you, who will listen to your concerns, and who can potentially find solutions for you. I think that's something that's really important to consider as well.
Yes, thank you for that. And also, um, one of the things that recently came up in conversation, actually with a friend of mine, well, it came up in work, but it also came up with a friend who is going through perimenopause. They're having all these challenges. They were speaking to their provider, and their provider, which I absolutely applauded, said, "We've kind of gone into a realm that I don't know how to fully help you. It's gone beyond my expertise. I don't have enough perimenopausal patients, and so they're going to refer her out." And I said, "That you need to keep that doctor. You need to keep that provider because they're being very honest." And I think it speaks to they're still going to, because that's a primary care provider for them. But for this particular issue, they need to find somebody else. And I would echo that for all of those that are listening as well, that when the time, if you can't find that doctor, but if you still like your whatever providers you have for other spaces, they can help you with those spaces, but find someone who can help you through these midlife challenges, and then and try to get them to work together, because that also, as you maintain that previous doctor or previous provider, allows them to see and they can learn and grow from your experience as well. So then when they get another patient, they've now learned something new through you that you're bringing back to them as you're seeking help through multiple care teams and you're interlinking them. And so there's um, Serene, for you, I have a question. Um, what are the consequences at a population level when women retire early? And maybe if you wanted to leap in some of the intersectional framework that you talked about.
Yeah, definitely. I think having women retire early is kind of a disservice to employers. You know, you lose really good talent, people who have been there for a long time. Um, and kind of thinking about the intersectional lens that I mentioned, um, community engagement is really important. And so when we're thinking about, people who are removing themselves from the workforce because of, menopausal symptoms or other chronic diseases during midlife, I think having the, I guess, lack of different perspectives really it impacts, I think, the productivity in the long term. There's a lot of studies in the workplace that show that, having similar perspectives doesn't really help with innovation and things like that. So that's more on like the business side. But I think in terms of making sure that you have a community, engaging them, and then even on the output, making sure that you're retaining talent and keeping costs low in that regard as a business, it's an investment for them as well. So that's kind of a little bit on that.
Great. And into that, I'm seeing there's some questions, and I'm trying to kind of summarize a bit when it comes to these needing accommodations, shifting this narrative from midlife being a liability to valuing women in this stage as an asset. And how do we encourage women to advocate for themselves, and not feeling like they're being perceived as less capable? And the reality is, these are health challenges. They are not they are not about capability, because you could do it a year ago, you could do it 2 years ago. So it's not you brain fog doesn't mean you don't know the answer. It's not coming to you. And so I encourage women to recognize it's still inside. It's just an issue of getting it out. It's almost like it's saying if someone covered your mouth, they might not be able to hear you, but you still have the answer to the question. And so we just need to do our due diligence as organizations, as healthcare providers, to help remove that barrier. And so removing the attention to it's an issue of a person to it's a barrier issue, and let's remove or adjust that barrier, and then the individual can fly and be the full uh, person and shine the way that they were. And so I think from that standpoint, SWHR, we have these resources. One of the things that we do is shedding light and resources for organizations and institutional resources and guides and awareness and conversations, because that way they're really understanding the scope of the issue and the scope of the problem, and addressing where can they make changes, because it is not a liability issue. It's really about um, retaining talent and understanding what those losses are. We want to encourage everybody there. I know we are running short on time, so I do have one last question that I like to close up with. We have diverse audiences spanning patients and healthcare providers, as well as researchers and policy professionals that tune into our online events. And so I'm going to ask everybody on the panel to share your suggestion for one solution. It could be a low-hanging fruit, or it can be a long-term strategy to support women as they navigate work-life health harmony during midlife. And I will start off addressing the healthcare community, and then I'll ask Serene if you can speak to the workplace leaders, and then Sarah, if you can speak to midlife women that are viewing this. And so for the healthcare community, I would probably echo or reiterate the example I gave, to be honest with the women that you're dealing with. This is something that we have not talked about for in the past very well. And so it is new, and it's new for a lot of individuals. And I think that honesty will go a long way with your patient community. So being honest and having conversation and discussing, um, and not, you don't have to know it all. And I think when we break down the barrier of having to feel like we know everyone knows it all, and I get it, as being a professional, you want to have that confidence. But I think identifying confidence and understanding that you have your own limitations, and then in sharing that, it provides the opportunity for you to learn, and to learn with your patients, and your patients feel a lot more comfortable in your hands.
I think I would say some like low-hanging fruit for workplace leaders is to consider, consider the benefits that you might have, whether that's flexible work hours, remote options, thinking about your health insurance and the type of coverage that you're providing, and then kind of launching or, enhancing employee resource groups that currently exist. I think, it's a strategic imperative, kind of what I was talking about earlier, which is, encouraging the innovation and retaining talent. It's key, I think, particularly as we talk about midlife for women.
And for midlife women, I think finding your community of support is really key. And I think that includes finding a provider who is trusted, or even finding a community outside of the medical system that you can offer support, whether it's an exercise group or a community-based organization. I think finding that community is really key as you transition through midlife.
Great. Well, thank you guys so much. Thank you to our panelists, our very own SWHR team of scientists, for your time, your insight, your transparency, and to Bonafide for their support of this event and SWHR's Midlife Health Program. To help women navigate midlife, SWHR has a suite of resources, including a fertility care resource guide to assist women in family planning and addressing infertility, a menopause preparedness toolkit that includes content about recognizing and treating menopause symptoms, preventive care for health conditions associated with menopause and midlife, including what we highlighted here today, and midlife health fact sheet to inform clinical and policy stakeholders about a comprehensive approach to midlife care. Understanding women's individual experiences and health journeys really helps us inform providers and policy decision makers on critical gaps in women's health. So SWHR invites you to share your story about menopause, about depression, about maternal health, or other women's health topics by visiting www.swhr.org/share-your-story. We've posted it in the chat. And we also invite you to connect with us on our website, swhr.org, as well as on all social media to download women's health resources, register for future events, and sign up for our newsletter. We will be sending out an email with the recording of today's event to all registrants, as well as post the recording on the event's webpage for future viewing. So please be on the lookout for that and feel free to share with others as we continue this important conversation about women's midlife health.